Bismillah ar-Rahman ar-Rahim. This is the third part of the updates in periprosthetic infection, dealing with an updated treatment guidelines. So in this video, we will go through the guidelines according to the pro-implant updated version regarding the surgical and non-surgical treatment guidelines for periprosthetic infection. So, treatment of periprosthetic infection is guided by the classification, whether it's acute or chronic, the organisms, whether we're dealing with a low or a high virulent organism, the state of the bone and the soft tissue, and the construct stability. In cases of acute periprosthetic infection, where you have an infection after the operation of less than 4 weeks duration, or a blood-borne infection with the symptoms of less than 3 weeks duration. If you have a 3-yes, that means that you have a good bone and soft tissue, a stable prosthesis, and not difficult to treat pathogen. That means that your pathogen is not resistant to the antimicrobials or antibiotics that are capable of penetrating the biofilm. If you have a 3-yes, so you can go to what we name the DAIR procedure. Debridement, aggressively, giving strong antibiotics, and irrigation and implant retention. Only you should exchange the mobile parts, because it has been proven that exchanging the mobile parts will lead to a less incidence of reactivation of infection. If you have a 3-no, that means that you have a bad soft tissue and bone condition, or an unstable prosthesis, or a difficult to treat pathogen like rifampicin resistant Staph aureus or ciprofloxacin resistant gram-negative bacteria or fungi like Candida. So there is no way to preserve the prosthesis you have. You have to go to prosthesis exchange immediately. Prosthesis exchange, you can do it either in one stage, in a single stage, or in 2 or 3 stages. This again depends on 4 factors. If you have a good and a bone healthy status, go for 1 stage. If you don't have a difficult to treat pathogen, go to 1 stage. If you don't have a fistula, that means aggressive infection or a bad soft tissue, and multiple revisions affecting your soft tissue or healthy condition of the soft tissue, so go for 1 stage. If any of these are yes, go to multiple staged revision, either 2 or 3 stage 3 revisions. In cases of chronic periprosthetic infection, that means that you have an adherent, irreversible bacteria to the prosthesis. You cannot remove the bacteria without getting rid of the prosthesis. So that means prosthesis exchange directly, either in a single stage or in multiple stages, as dedicated by the quality of bone and soft tissue, the virulence of the organism, as well as the status of the previous operations. The difference between the DAIR and the 1-stage revision is the ability to remove bacteria from the surface of the implant, and the ability of the antibiotics to reach the bacteria remaining. So, in early stages, while the bacteria is still not adherent and not covered by the biofilm, irrigation will remove most of the bacteria, and the antibiotics will reach the remaining sum of bacteria after the procedure. However, in cases of long-standing bacterial infection, the bacteria is totally adherent and covered by the biofilm. So its eradication or removal during the procedure, during the surgical procedure, is impossible, as well as the antibiotics will not be able to penetrate the biofilm to reach and kill the bacteria. In cases of two-stage revisions, we have two strategies, either a short interval or a long interval. This depends, again, on the quality of soft tissue, as well as the variance of the bacteria. Short interval means that the interval between the two sessions, the debridement and the implantation, is almost 1 month. The long duration means that you will wait for about 2 months for the second session. It's now not advised to wait for more than 8 weeks, as it has been proven that it's useless, especially with spacers, as the antibiotic concentration decreases to a minimal level below the inhibitory concentration. If after 2 stages it's unsatisfactory, you can go for another stage. If in multiple stages fail, so the only way left is the suppressive long-term antibiotic therapy. The principles of the debridement surgeries are clear. Eradicate and remove radically all the necrotic tissue. Do a total synovectomy as much as possible, because the clefts in the synovium will always harbor bacteria, preventing the antibiotics from reaching it. Excise the sinus tracts, and finally, irrigation should be used with the copious volumes of sterile saline. Other solutions may be lethal to the healthy tissues as well as the necrotic tissue, so rely more on sterile saline. In the DAIR procedure, you have to remove and replace the mobile parts. On the two-stage revision, it's debatable whether to use a fixed or a mobile spacers. However, the use of a spacer is much better than leaving it without a spacer. Spacers closes the dead space and maintains the joint stabilities, as well as maintaining some degrees of minor ranges of motion inside the joint. The most important thing, or the most important advantage of using a spacer, is providing a local antibiotics source inside the joint. Antibiotics loaded on the cement should be thermostable, so as not to be damaged during the cement setting. They should be water-soluble or hydrophilic, so to provide the highest concentration possible inside the joint. Usually we use 4 grams of antibiotics for every 40 grams of cement. The standard antibiotics types in cases of unknown pathogen is 1 gram of gentamicin combined with 1 gram of clindamycin and 2 grams of vancomycin. In the second stage, it's advised also to use a cement fixed prosthesis loaded with antibiotic. But at that time, we use 2 grams per 40 grams cement, so as to enhance the mechanical properties of the cement fixing the prosthesis. Going back to the cement spacers, It's advised to use an antimicrobial sensitive to the bacteria if you know the type of bacteria. It's not advised to use a vacuum mixing because the high porosity present will allow a better elution of the antibiotics inside the fluid. Moving to the non-surgical treatment, the antibiotics or the antimicrobials treatment principles. We should start empirical broad-spectrum antibiotics after surgical debridement. We should not start it before lowering the bacterial load before debridement. You should start it after surgical debridement only. Using a very high doses of antibiotics. The recommended antibiotics to be used empirically is ampicillin sulbactam 3 times per day. Every time you give 3 gram IV, or amoxicillin clavulanic acid 1.2 gram 3 times per day. 1.2 grams 3 times per day. Preserved vancomycin 1 gram twice daily to very ill patients like septic patients or patients known to have a MRSA carriers. Shift to the target therapy once the organism is identified. Switch to the oral after 2 weeks of IV if the oral substance has a good bone penetration and the wounds are dry. This is a new idea of using the antimicrobials in a multi-stage procedure. The goal is not to eradicate the bacteria. The goal is to have a maximum reduction of the pathogen. Antibiotic treatment should continue until reimplantation. You should not give a drug holiday, and joint aspiration is no longer recommended. After implantation, you should send the biopsies taken in the second surgery for cultures, and if you have a negative culture, continue on antibiotics for full eradication of the organism for 6 weeks. If you have a positive culture, extended to 12 weeks as if you're dealing with one-stage revision. The new recommendations for the length of administration of antibiotics or antimicrobials rely on the 12 weeks concept. For all types of surgeries, you will give a 12 weeks, a 3-month antibiotics. Different types of antibiotics will be recruited according to the procedures. For example, if we think about one-stage revision or their procedure. So, you will give IV antibiotics for the first 2 weeks in the normal fashion. But after 2 weeks, you should rely on oral antibiotics with anti-biofilm activity. That means that antibiotics that you will give should be capable of entering or penetrating the biofilm, assuming that the biofilm will be formed within 3 weeks. So after 10 weeks, the antibiotics given should be able to penetrate the biofilm to kill the bacteria. In 2 stages revision, the short interval with less than a month interval between the debridement and the reimplantation. So, with the first stage, you start with IV antibiotic without anti-biofilm activity. And after the reimplantation, you continue on 1 week only on IV antibiotics, on antibiotics not capable of penetrating, or the general antibiotics not capable of penetrating the biofilm. After 3 weeks, you should assume that the bacteria, if present, is capable of covering itself with a biofilm, so you should rely on an oral bacteria with an anti-biofilm activity. The antibiotics with anti-biofilm activity are mainly the quinolones, the ciprofloxacin, and the rimactan or rifampicin-loaded antibiotics. In two stages revision, long interval with an interval about 2 months in between, so you will divide them into 6 weeks duration. The first stages, you will continue in an IV in a normal fashion, antibiotics with a normal fashion for 2 weeks, and then oral without an anti-biofilm activity for another 4 weeks. And after implantation, you should resume 1 week of IV antibiotics without an anti-biofilm activity, and afterwards oral with an anti-biofilm activity, assuming that after the implantation of your prosthesis, the bacteria will be capable after 2 to 3 weeks to build up a biofilm. So you have to give an oral antibiotics with an anti-biofilm activity. So in summary, the surgical treatment is guided by the classification, the variance of the organism, and the state of the soft tissues and the bone, as well as the construct stability. In cases of acute infection, you can choose between their procedure with retention of the implant or implant exchange, either in a single or a multiple stages. But in chronic PJI, there is no choice. You have to go for implant exchange, either in a single stage or multiple stages. The non-surgical management, you should rely on very high doses of broad-spectrum antibiotics until you know the organism. Once you know the organism, you should aim at target therapy. You can switch to oral therapy after 14 days if you have a healthy wound and a good drug with a good bone penetration. Antibiotics treatment, new idea or new goal is not to eradicate the infection, however, to lower the bacterial infection or load as much as possible. Antibiotics should be continued until reimplantation, and it's not recommended to give a drug holiday anymore. Antibiotics should be administered on a 12 weeks interval theory. Thank you.